100% because they are. It's not the regular webinar model. Um, I will make some points with your two presentations. We heard from Prof. Kotari from Geoffrey Hinton, who is Canadian, British Canadian, from the University of Toronto. He was hired in 1987, so almost 40 years. He's been working and developing. So it's interesting that some of our Nobel Research Prize comes from Canada, not all the time from other countries. But I think my main criticism of AI and what we see is a little bit like when we had a lot of data. I remember when I was a researcher at McGill University, the professor used to say "garbage in, garbage out," and meaning that when you talk about the international registry, I can tell you that this international registry is inaccurate. For example, they have Canada data in the international registry, and this is only Ontario. Ontario is about 40% of the province, and Ontario is very biased in that this program of Ontario Bariatric Network that was started a few years ago only allowed Roux-en-Y gastric bypass, did not allow anything else. No band, no a sleeve, no DS, no SADI, no nothing. And for maybe 20 years, it was only Roux-en-Y gastric bypass that was allowed. So when you know that this kind of bias exists and you put this in the international registry, then the artificial intelligence computer sees this as, you know, the best thing that can ever happen to patients. And so if you multiply that for each country, it's a voluntary submission of data, mostly, sometimes individual centers or part of a country. And then artificial intelligence look at this international registry as if it was all correct and right, and not knowing the way it is being submitted and put together. And the data is voluntary, so as you may not see all the complication, you may not see all the outcomes from these different submissions. So how do you reconcile decisions that comes from inaccurate? I would say it's inaccurate because it's not a true picture. For example, in Canada, because in Quebec, it's totally the reverse. In Quebec, it's like United States. The surgeons do whatever they want, and as a result, 80% of the procedures are sleeve gastrectomy. So it's totally different than the province next to it, so which has an obligation to do only one procedure mostly. So that would be my difficulty, and I think. Shanu, you've been president of the ASMBS, and you know how new procedures are being vetted and submitted to the executive committee to a vote and having several years of follow-up. So are we going to see AI in a similar way? Because it's not being subjected to any, at the moment, any vetting from a society. Right now, it's whoever wants to use it, and there's no
regulation
system. So let's start with that.
Yeah, that's a great question. I think we can harness AI to help call the literature, but I would still think for the foreseeable future, it would still be humans sitting in a room voting thumbs up, thumbs down on endorsement of a procedure. Much like I shared in that one slide that Harold Bay says, they don't want AI writing the conclusion of your paper. You can use it for readability and syntax, but you shouldn't rely on it to do the critical thinking and come up with a conclusion of your results. And I would think that's probably how ASMBS would be for the foreseeable future.
Mhm.
Regarding the first comment that you made around the quality of the data going into the registries, um, I wonder, and again, I would defer to Dr. Pentelis because he has more expertise than me. Can we get to the point where we do eliminate the human variable? Much like that company that we're trialing with, the op note is generated off of what it really saw, not what you said you did during the case. It takes the human factor out of it. Can we get to the point where leaks and bleeds and blood clots and the procedure and length of surgery and length of time is automatically entered into this through the use of AI, and it takes the human factor out of it, so it really is, you know, accurate data. I don't know if we can to get to that point.
Okay, let me ask Professor Pentalis some things, and he has spoken on the leak risk. Um, if we look at the MBS QIP data, and you can see that, for example, the leak risk is of sleeve gastrectomy is 0.1%. That's 1 in 1,000, and bypass maybe 0.2%. 2 out of 1,000. I think that's what I remember from the last meta-analysis of MBS QIP. Um, you're going to be using this artificial intelligence to and be okay 99.9% of the time. And um, I saw your data going to 7 days. Patients are leaving the same day or the next day. So how useful is this going to be in clinical practice when the leak rate is so low and the patient is already home? Maybe in Greece they stay 7 days in the hospital. I don't know. That that would be my first question when I saw your leak thing. Is it going to be practical in real life? The second thing is you noticed Sophia. Now, Sophia was done by the CHU of Lille in France, François Patou and his associates. This is the data, their own data, that generated this curve. And that team was already biased towards Roux-en-Y gastric bypass, as you know. They did not include SADI or DS or other procedures. It's just sleeve versus bypass and projection of weight loss. The problem with that also is it doesn't include two-stage procedures. For example, you have someone with a high risk, and you're not going to subject this patient to a Roux-en-Y gastric bypass. You're going to do a sleeve gastrectomy. And this patient, is going to have a second stage at one point. That computer generation does not construct this correctly. Um, it will say sleeve gastrectomy was inefficient weight loss for this patient. you know, but that's how you constructed it, and so it's given wrongly an information to a potential patient who has a body mass index of 60, who's going to punch in his number and says, hey, sleeve gastrectomy is not going to be good for me. I want to bypass. And I see these patients coming in clinic and say, I want to bypass. The guy has a BMI of 65 and it's high risk. And you just try to convince him that that's not a good start. And he's at high risk of problems if we do a Roux-en-Y gastric bypass in a difficult male patients. Um, Interestingly, the country, France, is doing a randomized control trial of Roux-en-Y gastric bypass versus SADI. And interestingly, it's giving better weight loss. So Sophia will have to be redone and include perhaps two stages, perhaps SADI in it, etc. So you can have 500,000 people punching in the numbers, but the way it was generated initially, and as I say, it depends on the initial data you put in to generate this. What
Thank
do
you
you
for the
say
question.
of
I
Pentalis?
could briefly ask to both address both queries with one answer. That nowadays ChatGPT is my best assistant. It's not substituting my work, but I advise him or her or whatever. But to break it down in your specific questions, as you know, leaks are, of course, very low. We are not admitting the patients for 7 days, either in Greek. We keep them for 2 or 3 days, but no more than that. But you know what? That when it happens, it's dreadful, and it might have a very serious sequelae. We are at the begin. We are not at the beginning of the end. We are neither at the end of the beginning. We are at the beginning of the beginning. All these models are still models. Nothing can be applied in clinical practice, but we have made the first step. Small step for the man, giant leap for mankind, but I don't know if it will be a leap in the near future. But we have a scaffold to rely on to begin with. Regarding the SOFIA study, the same answer applies as well. It's a good tool. It's not inclusive. It has many defaults. It's relying on these two sleeve pass and the other RCT that exist in bariatric surgery, which are not ideal, but this is what we have now. And I would return to the initial questions that you addressed to Professor Kotary. There is a huge discrepancy between SMBS and the IFSO registry, because the SMBS registry is there for many more decades. All the centers are obliged to put in their data, and the practice is more or less the same. At least it has the same baseline. Of course, there are variations in individual practice of bariatric surgeons, but the baseline is more or less the same. You cannot apply this on a global basis, but at least that we are making some efforts to unite all the bariatric surgeons from all the places in the world. It's a good first step. Instead of seeing into ourselves, at least these technologies has given us the leverage to start cooperating. But still, I'm saying I would conclude that we are at the beginning of the beginning. None of these are to substitute clinical practice and clinical experience and common sense.
Yeah, I agree with you. I see all these efforts. It's looking fantastic, and selected things like mentioned by Professor Kotary and by yourself. And I think we will need to validate this in the near future. And there is a doubling time with these chips getting faster and faster, and hopefully they might get better than our good judgment. There's also the surgeon's experience, and how we know how that surgeons are not equal. You've got terrible surgeons, and you've got good surgeons, extremely good surgeons, and then you've got experience. We know, for example, that older surgeons have less complication than younger surgeons. This was published recently. I can't remember if it was JAMA surgery or annals of surgery. I tell them, to my young surgeons, I have less. It seems less risk than younger surgeons. Younger surgeons may take more risk. I don't know. There, for example, a female surgeon versus male surgeons. There's the surgeon's characteristics, which is not included in all of those, and it may come in the future. There's the surgeon as a variable, not only the patient as a variable. Any last comment, Prof. Kotary, and then Prof. Pantelis, and then we're near completion.
Yeah, I would just say, I'll give the last word to Dr. Pantelis, but I think he said we're on the cusp, and the next pilot, which will be taking place, is in the U.S. at least, is can the AI automatically extract the data from the EHR to the registry and eliminate the human variable and the cost associated with that? And that's right where we're at right now, and it might alleviate some of the human factors and the garbage in, garbage out thing. But all it would do is go back to how accurate is your EHR, which again, in the world of templates and autofilling, would we just replicate a different version of what you're saying? But time will tell. But I'm excited to see where the future lies.
Thank you. Thank you. Professor Pentales, last word.
I will just repeat what we all said. First of all, common sense. Second, clinical criteria and judgment and experience.
Okay.
This will not be
Well,
substituted by any machine learning or AI algorithm.
there is good hope with AI. Thank you very much for your presentations, both of you, and thank you for the journal for the opportunity to discuss this and have a webinar. Thank you.
Thank you for the invitation.
Thank you.